Hi, I'm William Blake. I'm the chair of the Board of Plastic Surgery in Australia, and I prepared this video to give trainees and surgeons an idea about the changes we're making to the assessment of the training program. And this specific video is about programmatic assessment. To my ears, that sounds like a complicated sort of term, but what we're talking about is just being organised and consistent in the way we assess trainees during their training. We've been using workplace-based assessments for several years now, but using them in a fairly sparse format with only small numbers of assessments done. Our plan is to use these tools more frequently with a goal of achieving a few different things. We're using larger numbers of workplace-based assessments to guide trainees as they move through the training program. We can indicate to them exactly what we want them to learn and which elements of those topics that they need to pay attention to. It gives us a nice concrete way of assessing improvement in performance, and it makes it much more clear what our expectations are at different levels through the training program. So we would distinctly expect an early set trainee to have less developed skills than a mid or a late set trainee. We would expect the WBAs to be an assessment tool which drives learning. So as time goes by, the trainees will be able to demonstrate that they have achieved competence and independent safe practice by accumulating a portfolio of WBA. They'll also know that they need to accumulate that portfolio, and that'll drive them to work their way through the curriculum. We're going to be using 5 different workplace-based assessments. Those tools will allow us to align our assessment very closely with the curriculum so that we can be confident by the time a trainee finishes the training program, that trainee will have covered the curriculum comprehensively and demonstrated a level of capacity which is commensurate with what we want to see at the end of the training period. I'm going to pull out a couple of examples here from the curriculum. One's more of an early stage, early set example, and then the second one's a little bit more advanced. And I want to do that to illustrate how we've structured things so that we can demonstrate that journey of acquisition of competence and safe practice throughout the training period. So the first of these two is about skin and soft tissue surgical management. This is an area we expect trainees to become safe and competent fairly early in their training period. This table has been lifted directly out of the plastic surgery curriculum document, which was developed a couple of years ago by a committee of our peers. It's a huge piece of work, so thanks very much to them. But now we can use this document. What this table is showing is that we would expect trainees in early set to develop an understanding of the diagnosis, management, treatment of skin and soft tissue wounds, but recognizing that there'll be some more complex elements that may be more appropriately expected of a mid-training trainee. The curriculum pulls out management of complex mold-resistant organisms and rare infections and sets them up in mid-set. By late set, we're not assuming any further development of skills in this particular area, and we'd like to see our late set trainees safe and competent in this space, but moving on to studying more complicated areas. This next table covers the same set of surgical tasks, but shows a progression between left and right, between early set and late set. And as we move from early set to late set, we'd expect our trainees to move from a state where they're doing these relatively simple tasks with some supervision or some direct guidance, and late in set being able to achieve the same tasks in a safe and competent way with minimal supervision. This paints a picture that all of these skills will be expected to be in place by mid to late set. If we look at the next one, which is craniomaxillofacial surgery, these are a more complex range of patients, more demanding procedures. And the skew here is developing skills history, talk about the nature of the diseases, and form some emergency care if required. But the more complex issues related to things like cleft lip and palate surgery, particularly the procedural and long-term multidisciplinary management planning, is something we'd expect of more advanced trainees. The final slide for this talk, looking at this here, we are same sort of chart as we looked at before, but the early set trainee is not expected to be doing these aspects of patient care independently, mainly requiring direct guidance. What's interesting on this slide is that we don't expect every trainee to be confident in every plastic and reconstructive surgery procedure by the end of the set program. So, for example, a trainee is not expected to be able to be safe and competent in craniosynostosis surgery, which I think gels well with the basic expectations that we might have about how our trainees come through the program. Indeed, I wouldn't expect a brand new consultant surgeon to be running a cleft lip and palate practice independently. And so, although we'd hope that our trainees can do those procedures by the time they finish the program, we would expect them to be doing them in a collegiate setting with ongoing peer review. And that's reflected in the way this table is structured. I'm going to record separately a talk about the individual workplace-based assessments, and those tools will be used day to day. But altogether, what we're trying to do is provide a systematic approach which documents the progress of trainees through their set experience. Thanks very much for your time.